Okay, this is our last section of lectures. There's actually 4 speakers. It's approximately 25 to 30 minutes per speaker. And then we'll have questions after all the speakers finish. Our first speaker is Dr. Shane, who is an energy master, clinical researcher. His background is in neuroendocrinology, stem cells, cytokines, molecular biology, energy, mind and body studies. He's the dean of a university in natural medicine. He's also a holder of one of the world's highest black belts in Taekwondo. He has a very interesting bio. In order for time, I'm just going to have him start speaking. Thank you.
Thank you very much for the introduction, and thanks so much for what's going on. So the title of my talk is Novel Regenerative Epigenetic Strategies to Ameliorate Acute and Chronic Inflammation. We've had an entire morning session and afternoon session on this particular topic. And in my view right now, the best way we can actually modulate this phenomena is not necessary through different types of drug treatments or pharmacological strategies, but lifestyle-mediated changes. Trying to get this slide. Okay, yeah, I think I got it now. Inflammatory peptides are expressed in many cells lines, especially T cells, distinct of bacterial strains of the gut. Now, something that really needs to be understood here, and I think there will be discussion of this in future conferences, is that we have more bacterial cells than we have normal cells. We are primarily bacterial in terms of the cell count. Everyone's going to give you a different cell count. From what I've understood, there's at least 2 trillion cells and as many as 4 to 5 trillion bacteria in our body. They have different strains, and obviously, if they're a cell, what do? They express proteins, and these proteins eventually get into our circulation, and they can wreak havoc. So it's really important to find strategies to actually change the behavior of our gut flora. Now, Barry Sears and others have talked about diet. Now, one of the issues that they don't bring up is that everyone in this room has millions of different genetic factors. So we're phenotypically completely different. So a high-protein diet, moderate carbs, low-fat may work great on me, but may not work well on him. So in dealing with your patients, you're going to have to do genetic testing in terms of looking at inflammation, likely IL-1, IL-6, TNF-alpha. You're going to have to understand, then you also have to look at some of the anti-inflammatory cytokines. So it's important for you not to believe the gospel that every one diet works well for every patient. And that's not true. Everyone's going to have a different gut flora. They're going to have thousands of different types of concentrations of bacteria in their gut. So it's important to understand here, and there will be some discussion in the morning about starting to realize, and it takes more time, unfortunately, that we have to have medicine that's not consistent for everyone. Because when you go into residency, you have a little book, and you go pain, symptom, and pharmacological strategy. And I think that when you get into practice, unfortunately, there's tremendous variability. For example, there was some discussion about exercise. Some people can get by with 20 minutes a day. Other people need a few hours. Okay, aging can be regarded, as has been said throughout the day, as an inflammatory disease. Stress-related lifestyle perturbations escalate inflammation and catabolic dysregulation. Lethargy and obesity further exacerbate this problematic conundrum. So what we have operating right now, we have a social reality that is inflammatory. Why is cancer escalating? Why is cardiovascular escalating? Why are we getting sicker? There was some mention that disease is out of control, but it can be in our control. And you, as captains of your patients, you have a responsibility to really try to educate your patient that they can do something about it. That somebody who has sleep apnea, who has other forms of insomnia, overweight, anxious, has problems in social relationships. These things can be ameliorated. But you, as a medical practitioner, you're going to have to be the one to do it, because the patient is coming to see you because they do not have the volitional acumen by which to make this happen. They wouldn't be seeing you. If somebody's healthy, they're not going to come see you. What they're telling you, the moment they walk into your office, if they have lumbar issues, or if they have tachycardia, or if they're so anxious that they can't concentrate at work, or they have sexual dysfunction, or they have forms of depression that's not based on anything in their external world, and they're resistant to any type of traditional antidepressant. They're telling you they have problems with modulating their physiology. And this is something that you, as medical practitioners, you have to deal with them, unfortunately. You went to medical school not to be a psychologist, but again, the psychological component is becoming very ubiquitous in integrated medicine. And unfortunately, whatever social factors you want to speak about, they're starting to escalate this epidemic that we are finding in the 21st century. Okay, inflammatory peptides are expressed in many different cells. This has been well covered. Chronic inflammation induces tissue degeneration and impedes homeostatic transcriptional activities. We are finding out that transcription is not what you learned in medical school, where a ligand sits on a cell membrane, goes through a signal transduction pathway, Pol2 is recruited, then you have a catabolic, and then that messenger RNA is transcribed, then it goes into the ribosome. It is far more complex than that. There are so many different factors that are now controlling it, such as the microRNA, various types of exomes they believe to be controlling it. So we have a lot of factors. We cannot just depend on the genotype. We have to look at lifestyle-related strategies as a way to control the way in which we remodel. All of you understand, as being licensed medical practitioners, the patient and the physician has a responsibility how the patient is going to remodel. We are nothing but trillions of different proteins that create tissues, and we can control, to a certain degree, at least the epigenetics. And people are now saying epigenetics is far more important than the actual gene itself. Okay, a younger obese phenotype is inundated with inflammatory cytokines, which accelerates aging. You all know about the type 2 diabetes. This is all common knowledge. Now, something that's going to be talked about at this conference and also in this session is adipocytes. We all know that visceral adiposity is a major issue. It is a risk for a myriad of different pathologies. And it's something that you, with the patient, can ameliorate. You can modify it. It doesn't have to be that way. And unfortunately, much of your role in the future will be motivational. You're going to have to be lifestyle experts. You know, you just can't tell a patient, well, take a statin, go home and lose weight, cut your caloric intake by 50%. You know it doesn't work. You're going to have to psychologically find ways to motivate the patient. A phenotype that is overweight, lethargic, has higher levels of inflammatory peptides in circulation, and may also have compromised joints and organ dysfunctionality. I mean, this conference today is really important. We've had some great speakers, and they're all saying the same thing, that inflammation is not a factor of, I think there was 4 things, the swelling, the redness, the pain. That's nothing. It's what's going on in terms of the molecular transcription. You've got to tell your patient that inflammation is not something simple. It involves, you have thousands of different cell types. They're all going to respond to a particular cytokine in a unique fashion, and each patient's going to respond to it. So if you can reduce the lifestyle epigenetic factors, you can really remodel your patient. There's nobody in this room that cannot have a very healthy, elite body. It's all about motivation. When I used to teach martial arts, I had people come in there, they could barely walk. And if they study hard, they can make tremendous changes in terms of what they can achieve. Okay, exogenous growth hormone replacement therapy in a deficient dose will mitigate overexpression of inflammatory cytokines, will inhibit adipose differentiation size, and likewise enhances lipolysis. So we all know about growth hormone. Many of you have been coming to these meetings for over a decade. There is some good evidence that if a person is deficient, not for anti-aging, because we can't say that, but is really clinically deficient, that growth hormone, along the lines of a certain type of diet and exercise regime, can really make differences on tissue remodeling. Okay, we all know that visceral adiposity reduces, GH reduces visceral adiposity, and it could also change the inflammatory matrix. Okay, I'm going to skip that because it's been talked about quite a bit. Okay, what constitutes the optimal lifestyle? Again, this is something that all of you as medical doctors, and I don't know how much I can hammer this home to you, you have to allow your patient to believe that they can really make changes in their way of life. They can really do that. You can look at the science behind transcription. You can look at the science behind translation. You can look at how certain activities induces greater cytokine expression. You can look at autoimmune diseases. You can look at certain types of cancer. But until the patient is willing to change the dimensionality of their psychological nature and change what they do during the day, you're not going to be able to make much changes. There was some mention in the early morning about lawsuits, about stress. Is it worth, if you have a patient, for example, that can make $1 million if they win a 3-year court battle, and you know as a medical practitioner, you're going to be changing the way in which their axons connect to dendrites, you're going to change possibly their various cytokines that are expressed in various cells. You're also going to change the way the amygdala and the hypothalamus is going to express CRH1. Are you going to tell that patient that they should go through that stress, or are you going to try to advise them that do they want to be in the hospital, do they want to be on chemotherapy, or do they want to have a healthy existence? We don't currently have any drugs that magically can reduce IL-1, IL-6, TNF-alpha without tremendous side effects. And we don't know how these drugs work in certain cells, and we don't know how they upset the balance between pro-inflammatory and inflammatory or anti-inflammatory cytokines. So we don't know that. We don't have anything in our arsenal of medication except for lifestyle changes. Okay, there are thousands of publications how certain foods upregulate colonization of certain bacterial strains in the gut, which results in enhanced systemic inflammation. I think this has been well covered by Barry Sears and by others. So non-homeostatic overexpression application of certain deleterious bacteria engenders chronic toxicity in the GI. This is something that everyone knows about leaky gut. Everyone knows about the fact that most people, due to D2 receptors in the mesolimbic area, they're addicted to food. Food is an addiction. It's just like alcohol or other forms of drugs. I mean, unfortunately, the culture doesn't put warning labels on certain processed foods. They should. It's just as deleterious as tobacco or smoking. If you're buying processed foods, and if you're not exercising, or if you're not practicing mind-related strategies to mitigate your overall stress level, you're not telling your patient what they need to know. They need to understand that they're overweight because their body's telling them something that they're not. It's not correct. If we went out in the wild for certain indigenous tribes, if you look at documentaries, everyone in the village is very fit. They have body symmetry. They seem to have inordinate health because they're not eating processed foods. Okay, homeostasis is something that is not being talked about at this conference. There's a concept called allostasis and homeostasis. And allostasis is when you change the physiological parameters of different tissues in your body. And what we're doing in the 21st century is we're becoming allostatic. We're changing homeostasis. Our bodies have evolved 65 million years ago when there was the first small mammals. So it had a long time to become homeostatic. The body is fairly succinct in terms of the parameters that creates a level of health. We shouldn't even be talking about health in the 21st century. It should not even be an issue. Why are we talking about it? We have a science that we never had before. We have the medications. However, we're becoming more ill every second of the day. Why is that happening? Because we're not paying attention to harmonizing the optimal homeostasis of various cell lines that have existed for 65 million years. Who are we to think that during the Industrial Revolution, which is 150 years ago, that we can make something better than the intrinsic homeostasis of the molecular dynamics of cells? And then we don't, and we're beginning to understand that we're living amongst bacteria. So they can be homeostatic with us, or they can be problematic. And what we're finding today is they're becoming problematic. I'm going to go through the diet stuff pretty quickly because I think it was really well covered, and most of you know it very well. Okay, so the issue, and this is important because I want you to take something from this lecture, not to just be bored by hearing the same thing, where you become able to do something about the situation. If I sit here and just give you what you've heard throughout today, what you've heard in other different conferences, I'm not doing my job well as a lecturer. I have to motivate you. I have to get you to inspire your patients to make some change. I mean, obviously, we don't want to live in a third world country because there's some really great things about what we have. What we need to do is to take education into volitional modulation of the executive functions of the orbital frontal cortex to where we see change in patient behavior. That's what we have to do. That's what, you know, you go to medical school and you get a kind of like overview of what you're going to do for 30, 40 years when you're in clinical practice. And clinical practice really is about dealing with the human phenotype, where that human phenotype will be more optimal. Okay, I think everybody can benefit by eating at least a third to 40% less. We don't need to eat so much. Food, does everyone understand the relationship between D2 receptors in the mesolimbic area in terms of pleasure? Because that's the issue why your patients are addicted to food. That's why they're addicted to heroin. That's why they're addicted to other drugs. Because they want that D2 receptors to be highly secreted. Dopamine is a reinforcer in the mesolimbic area, especially in nucleus accumbens. Obviously, tobacco, if the patient's on medicinal marijuana, eat it. Don't smoke it. Stop smoking. Avoid foods which are processed or manufactured. You all know that. But getting them to do it is your issue. That's your task. And there's no magical way to do that. People need to start really changing fats and sugars. And never eat anything that has glucose. Stay away from this stuff. It's toxic. It really is putting toxicity in your body. I mean, this is a standard: lean red meat, fish, poultry, avoid alcohol, select organic fruits and vegetables, stay away from salad dressings. You know, whether patients can do that, but this is something that seems to be quite, I don't think anybody would argue about this stuff. Again, the biggest issue is most humans today are stressed. Why are we stressed? Our culture makes us stressed. Do we have a mountain lion about to attack us? Do we have famine? Do we have to sit out in the cold and freeze? We do not have the same factors that we had 10,000 years ago. Imagine 10,000 years ago. There was no Walmart. There were no cars. There were, according to most anthropologists, we didn't become agrarian until about 8,000 or 9,000 years ago. So, you know, if it was super cold after the last ice age, we went through days of starvation. And it's not too much fun when that glucose plummets. Can't do much. You have to hunt. That's stress. I mean, what are we stressed about? You know, everyone has some degree of clothing. They have some degree of shelter. They can find some type of sex. They're reasonably healthy. Why are we so stressed? What is it about? We have nothing to be stressed about. If I had a time machine, I took you back 15,000 years ago, you might have a good reason to have IL-1, IL-6, TNF alpha upregulated. You don't have any reason to have it. It's you allow certain cortical circuits, super circuits, to become dysregulated. The reality, you all have pretty good lives compared to what humans used to live by. If you really want to see, read some of those anthropological studies of what was believed, how we live. Or go out on a safari and live with the chimps. See what hassles they have. Predation, famine, contentiousness amongst their groups, having a alpha break you if you're a man or female. So, we really have considerable less stress. Imagine if you walk away from where you are, some predator can actually work on you. So the stress issue is becoming ubiquitous. Obviously, everyone's heard about Tai Chi, yoga, hand and foot martial arts to reduce CRH1. And again, CRH1 translates into problematic inflammation. Everyone should know at this point in time that really this is what's happening. We are stressing ourselves out. I imagine that most people in this room have stress issues. And they really shouldn't. They should be happy that they're doing so well. Because this is the first animal, unless you're a killer whale or dolphin, where you have plenty of food and you're just cruising around, you have no predation, they probably have a better lifestyle than we have, but we could modulate our lifestyle in that fashion. Okay, again, we have to restructure the way we live. You can't tell the patient, well, sell your house, go through a divorce, try to reduce your stress, quit your job. People have to find a lifestyle that's going to work for them. You, as medical doctors, unfortunately, living in the 21st century, you have to tell your patients, I can't give you, all these medical studies, I can't give you drugs to help you. You have to do the situation yourself. We all know the STAR-D study. How many are you familiar with the STAR-D study on antidepressants? They don't work. They were evolved to work when there is a real loss of serotonin at the interface between the axon and dendrite. Most depression is very multifactorial, and it's not based on neurotransmitters. Currently, in the view, if you read the STAR-D study, we do not have any medicinal therapy to treat depression. And most people are anxious and depressed. They have to work on changing their way of life. We all should know that exercise has neuroprotective benefits, and it works better than in studies than using an antidepressant. And so we really have to get people to change the way they live, because as it was pointed out in the morning, people are getting sicker, younger and younger and younger. We all know that the obesity problem in young people today is close to 40%. They're going to be diabetic by the time they're 25. You're going to have to treat them. And it's a hassle to be diabetic, because if they couldn't reduce their caloric intake, they're not going to be able to monitor their blood sugar. You know that, especially if they're young. So this is a serious issue. And the only answer is not drugs. The pharmaceutical industry cannot create drugs fast enough that work. We've been around doing this stuff for decades. There's not much new on the table. There really isn't. Unfortunately, the responsibility is going to have to be on your shoulders because psychologists are not trained in medicine. And they really do not have really decent strategies to work with. So, getting lean muscle is really where it's at. I mean, I'm about 6% body fat. I work every day, at least 2 hours a day, to try to maintain my health. Because when I get up in the morning, that's all I have. I have a body. I'm not some mystical entity that can fly into a much more Elysian sphere. I have to deal with my body. So I have to deal with its inflammation, and I have to find ways to monitor it. Fortunately, I do a lot of stuff in the martial arts still, and I believe that there's a relationship between what the Chinese Taoists believe to be qi and inflammation. And that's a whole other subject, which I'm not going to get into. Somebody's welcome to ask me about that. So, obviously, hormones are great. We all know that. That's why we're here at this meeting. But again, hormones, I was talking to Edwin Lee about the pathways between the nuclear receptors for testosterone and for muscle genesis and through activity. We don't know much about it, but I can tell you that if you take a 6-year-old and give them 150 to 200 milligrams of injectable cypionate testosterone, and they sit around and they don't exercise, after a while they're going to have the same symptoms that they had before taking it. And I do believe that in that phenotype, it could be problematic. So, just giving testosterone, and there's going to be some talks about it throughout this conference, could be problematic, could definitely be problematic to the patients. I got 4 more minutes, so I'm going to wrap up on a couple things. What's new? And it's going to tie into what some of these lectures are going to be about. We all know that joint pain is out of control. And right now, there's some debate by using mesenchyme stem cells from bone marrow compared to the stromal vascular fractions from fat when injected to an arthritic joint can reduce inflammation. There's clear evidence, I don't think anyone would disagree, that stem cells, autologous stem cells, are anti-inflammatory. So it's something that does make sense. Some people are using placenta extract with IGF-1, with stem cells. Some people are just using PRP with IGF-1 in placenta extract. All this stuff can be beneficial. I think the first tier to look at is PRP. The second tier is PRP with human placenta extract. The third tier might be IGF-1. The fourth tier is to bring in stem cells into the joint. The next tier is to use fat as a scaffold for the stem cells. I think you all have heard of Joseph Parita out of Florida. He's using everything because he doesn't know what works and he doesn't know what is going to work for a certain phenotype. So all I can tell you, knee replacements, hip replacements, and shoulder replacements are a mess, a nightmare. So anything you can do in the embryonic stage of regenerative medicine can be beneficial. There are some research going on, which I'm involved with, which is using certain peptides in high concentrations to try to ameliorate this type of phenomena. So that's what's really happening right now. We don't have a lot to work with. It's not like, here we are living in 2015, and all of a sudden we can replace joints by growing them in a dish. We can't replace hearts. and who knows how long it's going to take. I think it's going to take at least 10 to 20 years before we really see a real change. And most of you will be suffering from the effects of a lifestyle that's inflammatory. Again, my take-home message is inflammation affects thousands of genes, which impacts many, many different proteins, which compromise your tissues, the structure of your tissue. So education, unfortunately, I hate to tell you this because you didn't go to medical school to be told that you have to monitor lifestyle. You were hoping that there would be a drug, or that there would be a therapy, or that there would be a surgical protocol. But again, one of the panelists is a plastic surgeon, and he can tell you if he wants to get a great result for 5 years from a facelift, that patient has to be optimal in terms of their overall remodeling. So I wish I could tell you that there was some phenomenal exogenous agents that can be utilized. But right now, you have to use the sagaciousness of your own perception to modulate patient behavior that translates into tissue genesis in an optimal fashion. Thank you very much for having me. I'm open to questions afterwards. And you can see my full lecture online. I think I've only hit about a third of my PowerPoint.
Thank you. For 5 minutes, we're going to take some questions, and our panel will be here. Any questions so far? Is there a microphone? We're going to give you a handheld microphone to get your question answered.
The use of Wharton jelly versus adipose cells. I did a study in culture on that particular issue, and I found that there were more effects in terms of microarray changes in the older genome when I used umbilical cord versus adipose. What has been your findings in terms of using other stem cell sources? Obviously, you want to keep it autologous, but in terms of really regenerating cartilage, do you think that other stem cell sources might be more judicious in terms of inducing hyaline cartilage genesis?
I think at this time, especially with older patients, it's still a numbers game. And I think on we read there are 400 to 2,500 times more stem cells in adipose tissue. So as you age, stem cells drop. So,
however, you and I did attend that conference, a stem cell conference, and too much, too little is too little, and every phenotype is going to have a different response in terms of what is going to be the optimal number to induce both changes in inflammatory cytokine cascades as well as the possibility of regeneration in terms of healthy cartilage. And as we both know, if you reduce the inflammation, you may get a naturalistic endogenous return of the proteins consistent with the cartilage matrix.
well, I don't think there is a right number yet, and some of the clinical studies using allogenic cells have looked at the difference between 50 million and 150 million cells. The problem is when you expand in culture, there's changes that occur, and getting such a high number decreases the homing capacity, and also there's changes in the cell and aging, because it ages almost 30 years when you divide it so many times. So the fact of what is a therapeutic number has maybe an important value, but we don't know what it is yet. I think more importantly is the differences in each individual. the niche you put it back into, and some of these other factors. I found just young athletes just do wonderful, and so numbers isn't really so important. It's what they have.
Well, it's something that you pointed out in your presentation, which is the kinds of different types of stem cells that you're injecting in. And no one yet on planet Earth has done the research to know which cytokines are necessary to induce the changes that we're looking for. So, as you pointed out in one of your slides, there's all these different kinds of peptides, and also these various cells are going to express different kinds of peptides. So it's a very complex interfacement that no one has yet been able to really clearly analyze and really know what the right answer is.
Okay. Let's take your question.
Yeah. I'd just like to say this. I've listened to your talks. I've been in preventive medicine for 45 years.
Hold the microphone higher. We can't hear you.
Can you hear me now? Can you hear me now?
I'd like to know which cytokines work, which are the workhorses, which are regenerating cartilage, which ones are reducing inflammation, and what is the crosstalk between them in terms of which concentrations are needed.
You know, why don't you come on up here and ask the question?
Okay, thank you. My name is George Guy. I'm from Seattle, Washington. I'm part of the Foundation for Care Management. I've been in preventive medicine for almost 45 years, and I've been through exercise with Ken Cooper in the Air Force. I worked for the Boeing Company for 25 years, being the chief of preventive medicine. I started many preventive medicine programs, and I've learned a lot. One of the things I've learned is that whatever we do, we have to do it all our life. We have to start in infancy, and it has to be done almost every day, every week, all our lives, from birth to death. The other thing is that the behavioral changes are as difficult, and I think I've learned that with smoking. Smoking cessation is very difficult. My smoking cessation programs back in the 80s produced 90% at 2 weeks, but only 10% at 1 year. So people went back. There was a lot of recidivism. As far as diet is concerned, Pritikin diet was very good. I think we tried that out, found out that it worked
George?
for a number of people.
Yeah. I'm sorry. It's late, and we just want to know what your question is.
Okay. The question is this. The determinants of health are not really in our power. What we see is the end stages of disease and at the end of most of the disease range. So we're really not looking at the right part of disease process. And so my point is this, that I think that we can't determine health by just trying to treat it and diagnose it. I think there has to be other things. There has to be controlled environment. There has to be diet changes which people accept and can use in the schools as well as other places. And I think we've done a good job with smoking, but not such a good job with hypertension and diabetes and obesity.
Thank you. Dr. Shane, you want to address that?
I think Dr. Gray is 100% right. However, he's not looking at the tremendous body of literature that is out there right now to really take a 20-year-old and set that 20-year-old on a epigenetically optimal lifestyle to where they're not going to get diabetes. They're not going to have a risk of cancer in general. And more importantly, they're going to remodel in a optimal homeostatic fashion. Cells do what they're told to do. They don't have their own volitional intent. They're affected, as some of the speakers said, by both their endogenous environment in the cytoplasm as well as what's happening in circulation. And this can also be modulated. We can control the situation. Now, it's very difficult to do because we've evolved a social reality that is antithetical to the optimal homeostasis of the human phenotype. So I do think that there has to be a concerted effort. If most of the population was able to give up tobacco products, and the nicotinic receptors in the brain are far more addictive than the D2 receptors in the mesolimbic area, it is possible. But it's going to take an overall cultural agenda focused on optimizing how we're living. 30 years ago, it was socially unacceptable to be obese or overweight. Now it is the norm. 70% of people have an abnormal BMI. It's acceptable. No one says anything about it. No one says anything about the fact that they're pre-diabetic. No one says anything about the fact that they have the risk of a cardio infarction. No one says anything about it because it's now the norm. It's a social norm. So it is important, as this clinician who's been practicing preventive medicine for 45 years, to start young. We have to educate people in high school about the fact that they can't sit there and twit on their cell phone 24/7, that they have to, because when you take a 10-year-old, and that 10-year-old has not learned to play, and there's no PE in their high school, and they rather watch a football game with their friends and not be active, what is happening, you're changing the motor cortex, you're changing the orbital frontal cortex, you're changing adipocytes, you're changing the satellite cells in your muscles, you're changing the axons in the peripheral nervous system, you're changing the entire gestalt of the organism. That person will never want to spend an hour and a half in a gym cross-training to at least eliminate some of the risk factors for a pathogenic lifestyle.
Thank you, Dr. Shane. We're going to conclude today. If you have any questions, you can come on up and just speak to the speaker panel up here. Thank you very much. We'll see you tomorrow.